eponymous fracture. You see, associated with the fractures of the mid one-third of the humerus, there is one eponymous fracture. Eponymous means a named fracture. A named fracture which has got some characteristics. So what is Holster-Lewis fracture? Topic is Holster-Lewis fracture. You see, it has got two components. It is a spiral fracture of mid one-third humerus. It is a spiral fracture in the mid one-third of the humerus associated with, so it is found to be associated with radial nerve injury. Alright. So if you are wondering that what exactly this Holster-Lewis fracture is, so these are the two components of the Holster-Lewis fracture. One is that it is a spiral fracture of the mid one-third of the humerus, but it has to be associated with the radial nerve injury in order to call it as the Holster-Lewis fracture. Now just try to understand. Imagine if we are having a humerus bone, alright, and there is a spiral fracture of the humerus bone without any radial nerve injury. So this also is a possibility, but this is not going to be called as Holster-Lewis. Similarly, if the fracture is transverse or if the fracture is oblique associated with the radial nerve injury, even then it is not going to be called as Holster-Lewis. In order to call this fracture as Holster-Lewis, there has to be two components fulfilled. One is that it is a spiral fracture of the mid one-third, and second is that it has to have associated radial nerve injury. Alright. So hope everything is clear related to this topic in particular. That means the fractures of the mid one-third of the humerus, and this is how you treat the fracture of the mid one-third of the humerus by surgical means. Alright, there could be a placement of intramedullary nails, or you can fix it by the placement of open reduction internal fixation by the placement of the narrow NDCP, that means narrow compression plates. Alright. Now, although it is not going to be kept in your examination, but you know, if we place this intramedullary nail, it is also not considered to be the best method, despite the fact that we are not opening the fracture site. It is just closed reduction, but it is not considered to be the best method for the management. Alright, the best method for the management is having a compression at the fracture site, which is achieved by the placement of NDCP. Now, some of you might be wondering that why we have applied this anterior plate also, that means reconstruction anterior plate. This is just to prevent the bending force of the biceps muscle, because there is a very common complication associated with the fractures of the humerus, which is managed surgically by the placement of this narrow dynamic compression plate over the anterolateral aspect of the humerus, that it will break, the implant will break along with the refracture of the bone once there is a too much of the biceps compression happens. So in order to block that compression, in order to counter that compression, we are applying this anterior plates as a reconstruction plate. But highly unlikely they are not going to ask you this question, but this is just for the purpose of understanding and explanation. Alright, so hope you have understood everything related to this particular topic. That means the fractures of the mid one-third of the humerus. The most commonly asked question out of this topic for you remains the most common nerve injury, and second is that how to manage this conservatively and what are the likely complications associated with this. Next topic when we arrive is the anatomy of the elbow. Now, you know, before we talk about the fractures around elbow, the dislocations or the complex injuries involving the elbow, it is important to have a discussion on the anatomy of the elbow itself. Alright. So first we are going to talk about the anatomy of the elbow joint. Now, although this is the kind of the X-ray where we are having the fixation of this bone, but if you look at this elbow joint is made up of the distal end of the humerus. It is made up of the distal end of the humerus, the proximal aspect of the radius, and the proximal aspect of the ulna. Alright. Now, some of the times what they are asking is, they are also asking about the questions related to the anatomy itself. They will just give you the X-ray and then they will ask you what is the name of the bone which has been highlighted. If we take the example, for example, if I mark this bone over here, alright, and by marking this bone, I ask you what is the name of this bone. So it is actually the head of radius. Similarly, what is the name of this region of the bone? Alright, the medial aspect of the medial end of the humerus. It is the medial epicondyle. Similarly, this is the lateral epicondyle. Now you will say, how have you decided that this is the medial or the lateral epicondyle? You have to look at the radius and ulna. The radius is the lateral bone, the ulna is the medial bone. Alright. Now, anteriorly, the articulating surface of the distal end of the humerus, which is articulating with the olecranon process of the ulna is the trochlea. So this is trochlea. Then the articulating surface of the distal end of the humerus, which is articulating with the head of the radius, is capitellum. So this is capitellum. Alright, so this is what you can observe on the anteroposterior view. So this is also a possibility that they might give you the X-ray and then they put the arrow over to the bone, over to the region of the bone, and then they will ask you what is the name of the bone which is visible over here. Alright, so lateral aspect of the distal end of the humerus, which is articulating surface, is the capitellum, while the medial aspect, it is the trochlea. Now if you look at the lateral end, or if you look at the lateral X-ray of the elbow, so the head of the radius is very clearly visible. This is the distal part of the humerus, but here is the entire olecranon of the ulna which is visible. So this is the olecranon process. Alright, so this is the olecranon process. Now, why this lateral view is important? So as to make you appreciate that what exactly or where exactly the coronoid process of the proximal part of the ulna is located. Now, if you look at this triangular region over here, a triangular piece of the bone. Now this is exactly what the coronoid process is. Alright, so this is point number 1. When we talk about the anatomy of the elbow, it is important to have a discussion on the X-rays of the elbow, normal X-rays of the elbow, because they might ask you what are the names of the bones you are dealing with. Hopefully you have understood everything and you would be able to identify the name of the bone. And obviously this is the radial bone and this is the ulnar bone, and here in the lateral view also the radius and the ulnar bone. Alright, next let's have a discussion on the ossification centers around the elbow. Now, you know, what do you mean by the term ossification centers? We have talked about there are so many articulating, so many small bony surfaces which are considered to be the secondary ossification centers of the bone, which are going to be a region of the elbow joint. So there has to be some ossification centers and they are going to ossify. They will be made visible on the X-rays at some particular age. Alright, so the table which we are about to construct is related to the secondary ossification centers and at what age they will appear on the X-rays. Alright, so first one is the capitellum. You know, it is the capitellum which will appear earliest on the X-rays. Then second is radial head, the head of the radius. Then the third one is medial epicondyle, the medial epicondyle of the humerus. Then fourth one is trochlea. Fifth one is olecranon. And the sixth one is lateral epicondyle.